Use it or lose it, aging, activity, and mature athletes. So, with great pleasure, I introduce to you our distinguished faculty. Ms. Nina DePaola, who is Vice President for Orthopedics and Rehabilitation throughout the health system. Dr. Jeremy Boal, who is our Chief Medical Officer and is a board-certified geriatrician. Dr. Elliott Hershman, who is the Chairman of Orthopedics at Lenox Hill Hospital, which, as you know, is our newest jewel in the system.
Elliott, wave. Elliott, wave. Okay.
Newest jewel in the system in Manhattan. Dr. Thomas McGinn, who is our chairman of the Department of Medicine and is board certified in internal medicine. So, did you know that the average lifespan in 1900 was 47 years, and the average lifespan in 2007 is now 78 years? And it is known that by 2025, 30% of all the people in the United States will be older than 55. In fact, by 2030, 20% of the U.S. population will be older than 65. And there has been a 232% increase in the population of individuals older than 85 between 1960 and 1990. So what a wonderful thing to be able to see what's going on in our society, and I think firmly affects everything we're going to talk about today about staying active, staying healthy, and not losing it. Problem is that less than 30% of those people over age 50 actually do any regular exercise. What's interesting, though, is in that same group, 78% will tell you that they think exercise is important. So obviously we have a bit of a conflict, a bit of a mismatch in terms of what we think we should be doing and what we actually do. Now, we do know there's a lot of reasons for that. It can be due to pain and arthritis. It can be due to injury. It can be due to concern that somebody will get hurt. And I think that's what our panel will help us learn a little bit more about, is how can we increase and close those numbers. Now, there are a number of effects of aging. And we all know that as we age, we all are going to have a tendency to put on a little bit of poundage. But there are other issues. And I'm not sure if you realize, if you study the physiology of humans, that essentially there's a growth curve that occurs as far as development of muscles and bone and the neurologic system that slowly increases to age 26. And at age 26, it levels off, and then at age 30, it starts to deteriorate. So it starts at age 30. And what occurs is each succeeding decade, from 30 to 40, 40 to 50, 50 to 60, there is a precipitous loss of muscle mass and strength, bone mineral, obviously issues related to eyesight, balance is reduced precipitously each decade, and of course the issue of vascular insufficiency. And you know, a lot of people say, gee, I don't feel strong, but what they may have is they may have an underlying vascular problem that inhibits their ability to exercise. So we do see aging starting early on, except the most important point about that is that there are things we can do to change that drop in muscle mass, to change the drop in bone mineral. And I think those are the areas that we need to key in on. Now, we have a patient for presentation today, and our patient is John. And he's a 66-year-old politician who is a very, very significant politician in the city of New York, who his last name shall remain right now confidential, who developed pain in his left calf while he was playing a tennis match. And he noted a pop, and he wasn't able to finish his game. In fact, he needed to limp off the court. He couldn't really walk very well. He sat on the side of the tennis court and developed immediate swelling. and he wasn't sure what he was supposed to do. So let's go to a question. So I would pose to you, what should John do when he gets home? Number 1, walk it off. Number 2, take 2 Advil. Number 3, wrap his calf in ice. Number 4, put on a heating pad. Number 5, elevate his leg.
I've had choices since
So,
the
6 seconds.
day that I was born. There were voices.
62% have answered wrap his calf in ice. Interestingly, 2% said put on a heating pad, 29% elevate, and as you can see, Advil and walk it off. So, Dr. Hershman, question for you. Obviously, our distinguished attendees feel that ice is better than heat. Any opinion on that?
Clearly, number 3, wrap his calf in ice, is appropriate. And you can remember the mnemonic, RICE, R-I-C-E, for any acute injury. So rest, ice, compression, elevation. I hear it over here. And you can use that as first aid treatment for any acute injury, any musculoskeletal injury. Just keep that in mind. Ice is the best treatment for acute inflammation and acute injuries.
Dr. McGinn, how long should we use the ice? 1 day, 2 days?
I think, on and off during the first day, and depending on the pain and the swelling, you continue it through the second day.
And how about Advil, Dr. Boal, in terms of medication? What do you think about that?
For somebody who has a relatively uncomplicated medical history where Advil isn't contraindicated, and the injury is relatively minor but uncomfortable, I think in many cases it would be reasonable to try a short course of Advil as well. Again, just recognizing that even a medication as simple and as commonly used as Advil can have interactions with other medications that people are on and have side effects.
And Ms. DePaola, should he try to walk it off, do you think? Should he go home and basically elevate his leg? What do you think? Is there any value to trying to stretch immediately that either at the court or when he gets home?
Typically, the first day, what we like you to do, like we said prior, was RICE. So basically, rest it, elevate, put ice on a few times for at least 10 to 15 minutes just to numb out the area. Give it a day or two. If it still feels stiff and it's acting up, you should probably seek some medical care.
Okay, and I would just comment on that I think these points are all absolutely correct. I think you should take it easy. The key thing with Advil is that most patients don't take the right dose. It's an over-the-counter medication, and if you look at your size, and if you don't have any other medical problems, such as kidney problems or liver problems, the actual dose of Advil can be 2 to 3 times a day. Some patients will take 2 once a day. And remember, Advil is a 200 milligram pill. If you take another over-the-counter anti-inflammatory agent, such as Aleve, you need to take 1, sometimes 2, twice a day. The other point about icing is short bursts of icing, 15 to 20 minutes on and off. Some people say, gee, I'll leave the ice pack on for 40 minutes because more is better. Wrong. You actually do a much better and more effective reduction in inflammation methodology by placing the ice for 15 to 20 minutes, and then we try to say do that 5 to 10 times a day. So you're really very diligent about icing. Some people say, what about heat after 48 hours? And in general, we say no. That despite the fact that we were always taught heat after 48 hours, ice for the first 48, we think that ice is a continued pain reducer as well. If there's swelling and inflammation, ice will continue to be valuable beyond 48 hours, and that's key. And then the issue of an ACE bandage and anything that gives you compression effect, I think, is a very good option. It's a very good practical option. But when you get home, you're sitting at home and you're thinking, gee, what is the next step? Did I do something?
We have a question here.
Yep.
I didn't know if I could interrupt at this point, but
Please.
You mentioned Advil and Aleve, and I thought I read recently that Aleve is better to take because of the way it's metabolized. I didn't pay that close attention, whether it's in the liver or kidney. Can you comment on that?
Absolutely. Dr. Boal, would you comment on?
So I'd be happy to comment on it. You know, there have been a lot of studies comparing the different medications in this class of anti-inflammatories, things like Aleve and Advil and the like, and it turns out that they're almost identical in terms of how they're metabolized. There may be very subtle differences that the pharmaceutical industry may want to highlight to suggest that one is better than the other. But going back to Dr. Sgaglione's point, the primary issue is the dose. If you take enough of any of them, the right dose of any of them, they'll have a very similar effect.
Is there a difference between generic and name brand, Dr. Boal?
There's no difference between generic and name brand. And in fact, for a generic to be produced, the company that's producing it has to demonstrate in very carefully designed studies that it's identical in its action.
Yes. Right. So the question is, if he was John and he noted a pop and he came home and he couldn't walk, he'd go see a doctor. So that's a perfect segue to the next slide. Thank you.
Thank you.
And thanks for coming.
We appreciate that. You can go home now.
The chairman of the Department of Medicine. Okay. So anyway, for our panel, I'm at home. Who do I call? Do I go to the emergency room? Do I go and call my internist, my primary care physician? Do I see an orthopedic surgeon? Do I go to a chiropractor? Dr. Hershman, who should I see?
Well, I generally would recommend that any individual with an acute injury or an acute problem first make the first call to your primary care physician. I think that's the place to start. If the primary care physician feels that a referral to a specialist is indicated, then that's appropriate, and that would be the path to take. But many times, the differential diagnosis, as we're going to discuss, can include a variety of conditions, not only musculoskeletal. So the primary care physician can help sort that out, and I believe that's the place to start.
But
So I call my
Elliott,
primary-
Can I interrupt here?
Pardon me?
Can I just interrupt? I'm going to interrupt anyway, so you can't stop me. So the question is, do you need to? It sounds like you don't want to be woken up in the middle of the night for this, Elliott, and I'm like you. I don't want to be bothered. But when should somebody call a doctor about something like this? Even back it up one more. Before, who do you see? Do you need to see anybody? When did you decide you should see somebody? And Elliott, when should they see
So
somebody?
what we like to call that, and you'll see this also commonly expressed through our day, is that is, what are the red flags? The question is, how do I know that I need to do something about this, and how do I know I just have a pull that's going to be better in 3 days? So Dr. McGinn, you want to answer that?
Yeah, I mean, this is there's no clear answer to these sorts of questions, but there are some hints. I mean, particularly if you have a very difficult time walking on something and bearing weight, the inability to bear weight and find yourself limping, I think you need to call somebody and talk to them. If you have if you respond to your analgesics rather quickly with a little rest and a little ice, you may just say, fine, this is something that I'm going to get over. But obviously, if you don't respond to that, process, you need to make a phone call. I mean, there are some very obvious things. If you have a large amount of swelling or a large black and blue mark that you didn't really think, why is that there? I mean, these are all hints that you need to make a quick phone call versus just sit it out.
So that's very good. So 3 take-home points: inability to walk or severe limping, 2, immediate swelling that doesn't show up 3 days later, and 3, significant pain. So if you have pain that really is bothering you, I think you need to see someone. So let's take Dr. Hershman's suggestion and expand on it. I call my internist, and I don't get a call back. Now
We
what?
always call back.
In your department.
I just want to point that out.
Okay, so Dr. Boal, I'm waiting, I'm sitting by the phone, I called my internist, it's Saturday night now, it's 9 p.m. What do I do?
So, I think the most important thing is if you feel that you need to speak with a physician and you can't reach your regular physician, then, you have a variety of options. I don't think I would accept that I couldn't reach somebody and just leave it. If you really felt that it was important to speak to somebody, I would pursue it. And that can be by contacting, if you have a relationship with a specialist, whether it's a rheumatologist or an orthopedic surgeon, or thinking about getting yourself to an urgent care center and being seen. Because again, if you're worried enough to pick up that phone, then from our standpoint, it's very important that you do either reach somebody or see somebody.
Good. So the question now is, we go to the emergency room, and the emergency room says, we think you have an injury, go put the ice on, get an ACE wrap, et cetera, et cetera, et cetera. But you need to see a specialist. And the question to the panel is, when? Do you go the next day, on Sunday? Do you try to get the first appointment Monday morning? What if you call on Monday morning and the specialist says, well, I'll see you next week? Is that satisfactory? Should you go in 3 weeks? So, Dr. Hershman.
Okay. Certainly in the situation where you have inability to bear weight, a lot of swelling, can't move your foot up and down, and it's really painful, time is of the essence. You want to see a physician relatively soon, and you need to make your case to your physician's office, okay? Many physicians, of course, set aside time for urgent situations, and will see you late in the day, early in the morning, when they can fit you in. In this situation where someone's felt a pop in their calf, the calf is swollen, they have difficulty walking, the patient should see you relatively soon. If you have an ache or a pain and you're getting around relatively well, that's a situation when they say, we'll see you in 7 to 10 days because that's our first opening. That's probably more acceptable.
Precisely. I think the point is that if the emergency room says you should see a specialist in the next 48 to 72 hours, I think it would be important to follow that advice. Many times the emergency room is going to make the correct diagnosis, but I think sometimes the expansion on treatment is really what the specialist might help you with. So let's talk a little bit more about the concept of what might be going on. And let's share with you a little bit about the bony anatomy. And if you will, look to the screen to the left, and I'm going to point out a few things. And for those on the right, if you follow this along, you'll see that the anatomy of the lower extremity for John's injury, where he injures his leg, always starts with the bone. And then we will work out superficially. And it includes the femur, which is your thigh bone. Then that articulates with the knee at the level of the tibia. So your tibia is your shin bone. And what's interesting is in your lower leg, we call the leg the area of the body below the knee. Okay? So that's the lower extremity. That part of your body is actually composed of two bones, the main shin bone, which is the tibia, and then the smaller fibula. 85% of the load of your leg transmits through the tibia and only 15% through the fibula. So a tibia fracture is far more serious than a fibula fracture. And then they coalesce at the level of the ankle joint. Now, what's very interesting about anatomy at the level of the lower leg is that you have a tremendous concentration of load. Your entire body is essentially funneled through the knee. And obviously there's two, but you have at the level of the knee what's known as the plateau. It's a widened, if you will, funnel-shaped portion of the top or proximal aspect of the tibia. So I think what we always want to know when someone gets hurt on a tennis court and they can't walk, we want to be absolutely certain they didn't sustain either some type of a broken bone or a fracture or even a stress fracture. And I like to say a stress fracture is almost like when you have a crack in a windshield. And that crack in the windshield can propagate, and you're going to worry about that windshield, versus a full fracture or complete fracture is when the entire windshield is shattered. We also have to be concerned with the soft tissue anatomy because obviously if I'm going to take the call from John about his injury, I probably am going to think he didn't break his leg. He probably has a soft tissue injury. And the soft tissue anatomy of the lower extremity includes obviously muscle, which is the calf muscle, which is the gastrocnemius. And that is a two or bifid muscle. It's a two-part muscle that coalesces into the Achilles tendon. But there's a third part to it, And that's why we call it in Latin triceps suri. And the third part is known as the soleus. And the soleus is the deep muscle of the leg, and then superficial to that is the gastroc, or the calf muscle. And obviously, these three parts, the two halves of the gastrocnemius muscle and the one soleus, come together in one large tendon. In fact, the largest tendon in the body, the Achilles tendon. And I like to tell patients the Achilles tendon is like a transmission. If you rupture your Achilles tendon, you're not going anywhere. The car is not going to move. You've essentially eliminated your ability to ambulate effectively. So, what we like to do in making a diagnosis is we like to think about what happened to the patient. So there's the listening to gain a history. Then we like to examine the patient, and that's our physical exam. And then only thirdly do we get tests. And some people will say 75, 10, and maybe 15% in that order. That is 75% of making a diagnosis will come from listening to the patient. So we're already thinking about what this might be. And there's several things. It can be a fracture. Patients will say, well, is a fracture the same as a break? Yes. So you can break your bones or fracture your bones. What's a strain versus a sprain? A muscle injury is a strain.
So if I can interrupt, Nick. So how do you know this guy doesn't have a fracture?
We're going to get to that. But I'm thinking on the phone, okay? He's coming in, and I'm thinking about his differential diagnosis, because I have to tell him he needs to come in right now. Or if he calls me on Saturday night at 11 and I don't have office at that time, I have to get him into the ER where I need to meet him because
But that can be arranged. You can have office hours at 11 p.m. Saturday night.
That's right. Yeah, that's right. Or meet him in the ER. So I think the thing is we're always thinking, and that's why I put fracture first. But we also have to talk about muscle injuries or strains or pulls. We have to also think about ligament injuries. So what's the ligaments? What are the ligaments? Ligaments connect bone. So bone to bone, ligament. Now you can have a ligament sprain or injury. You can rupture a ligament. You can essentially have a sprain, which is essentially a stretch. And we like to say that ligament sprains can be grade 1, where they essentially have an injury where they stretch a little bit, a grade 2 where there's a partial tear, and a grade 3 sprain, which is a complete tear. So you can have a wide variation of sprains. And then there's tendons. Tendons, as you know, connect muscle to bone. So ligaments connect bone to bone, tendons connect muscle to bone. So if you have an injury at the muscle portion of the muscle tendon unit, that's known as a strain. If you have an injury at the tendon or the rope-like portion of the muscle tendon unit, which connects close to the bone, that's either a tendinitis, an inflammation, or you can have a tendon tear. So we're thinking immediately based on the information we're hearing. So how do we get to a diagnosis? So we've listened and we've thought. Now we want to examine the patient. So I'd like to demonstrate for you, if you allow me, a physical exam. And we have Kevin Caraccio, who's here today to help us teach you how we would approach a physical exam. Am I on? Okay? Yeah. So thank you. Hi. So what I like to do in an exam is the first thing we do when you greet a patient and you say good morning is I'm watching the patient walk. I'm watching the patient come into the room. So for instance, if Kevin came into the room and he's limping, I'll just move back up a little bit, so Kevin comes into the room, I'm watching immediately what type of a gait he has. Okay, good morning. Please have a seat. I take my history first, and I like to hear about in person what happened to analyze the process of the injury. I want to know about did it occur during the play? Did he just turn suddenly? What was the mechanism of injury? Then I would like to take a look, and we call that inspection. So we'll actually take a look. Can you lie down, please? And good. And what I will tell patients to do is they'll get very nervous and tight, and they'll flex their knees up. So I'll say straighten out their knee. Obviously, we have an injury to the left leg, so we will inspect the leg, and look at all sides of the leg. You want to look for the amount of swelling, obviously shoes and socks off, and you always want the other leg to have shoes and socks off too, because we're constantly comparing what is abnormal with normal. Then after inspection is palpation. So we will then actually feel the area and say, first I like to say, what hurts most before I start touching the patient? And I'll say, so Kevin, what hurts the most? Show me the spot. Okay, so he now points to the spot that hurts the most, but I will examine the other side first. That does several things. It disarms him. He knows that we're not going to come in and be too rough. What it also does is it gives the patient the sense that we're not going to touch the spot too roughly, so he understands, I think, the level of tactile approach to this. Then we'll go to the area, and obviously we're correlating anatomy with the injury. And in this particular case, the injury is in the mid-calf. It's on the inner or medial aspect of the leg, and we divide the calf into threes: top third, middle third, bottom. Now, if this is a middle third injury and there is marked tenderness in that area, that's telling me more muscle. If he says it's down near the Achilles, that's different. That's now tendon. So we're drilling down and we're more precisely defining the pathology. In addition, I want to grade this. Is this a grade 1, which is just sore? Is it a grade 2 where I feel a little gap where the muscle pulls apart and you can actually feel a bit of a hole or a defect? Or is it a grade 3, which is a more significant defect? And obviously we want to check other things such as his circulation and feel his pulses, his nerve, and make sure his foot moves normally, and that would be part of our exam. There's one test I want to show you because people are always fearful about Achilles tendon ruptures. The reason is that many Achilles tendon ruptures require surgery. Not all, but many. And so in contrast to a pulled muscle, which may have a different treatment and almost never need surgery, an Achilles tendon rupture, you have to start to at least entertain the concept of surgery. And one of the ways we like to diagnose that is, could you turn on your stomach, please? And this is a test called the Thompson squeeze test. And what it does is very, very simple, but very accurate. It's very sensitive, very specific, and very accurate. Is we actually squeeze the calf, and we're not touching the ruptured Achilles tendon area. And by squeezing the calf, if you look at Kevin's foot, it moves his foot. And that shows there's continuity between the calf and the foot. If he had a ruptured Achilles tendon, we would squeeze the foot and it wouldn't move, squeeze the calf and it wouldn't move the foot at all. And obviously, if this is the normal, the left is the normal and the injured is the right, we have a normal Thompson on the left, and then when we squeeze the right, it's dead. That is pathognomonic, which means almost virtually certainly consistent with the diagnosis of an Achilles tendon rupture, which is something we don't want to miss. You don't want to misdiagnose an Achilles tendon rupture and think it's a calf muscle pull. Thank you very much.
Questions?
Yes.
I had a question. You had a slide up before. I guess fracture, sprain, strain, and tear. I'm not sure I have them in the right order. But
yes.
My question is, can each of these cause a popping sound?
Good question. Yes. And more important than that, there are other things that cause popping that actually include none of these. There are things that people will say, my knee popped, and they actually have nothing anatomically wrong. But obviously that's a diagnosis of exclusion. But all of these things can. Broken bone, much more dramatic. The more milder sprains and strains, less dramatic, as well as tendon injuries. But realize when you rupture a tendon or a ligament, that produces a pop. And when you injure and stretch a muscle, that could produce a pop.
I'd like
Yes.
to share an experience I had last week. I had surgery on my vocal cord with general anesthesia on Long Island. That was Monday, and on Tuesday morning, when I got out of bed, both of my calves were killing me. I couldn't walk. I called my physician. He did a thorough exam, and he said, you've had deteriorated herniated disc for 50 years, and when you were under general anesthesia and manipulating your body, the pain, instead of going into your back, went bilaterally into the calves. I was put on Mobec, and within 3 to 4 days, everything was gone.
Right.
What do you attribute that to? Is that...
Right. Yes. I'll just comment quickly on that when we're in the operating room, part of our preparation for surgery, as you would only imagine, is careful positioning and padding. We spend an enormous amount of time before we start, after the patient's asleep, to prevent some problem with positioning that could cause irritation. Yes?
There's a problem taking certain antibiotics like Levaquin causing the rupture of the Achilles tendon. How does that happen? And does it also cause a problem in other places besides the heel? Because I had taken Levaquin last week after a dental procedure, and coincidentally, I was talking to somebody yesterday, and we were talking about that antibiotic, and she told me what happened to her knees. And I said, you know what? I woke up a couple days later, I've had to go to the doctor for my shoulder. My arm started to hurt, and now he said I had tendonitis in my shoulder. So is that from the antibiotic? And how does that medication cause a rupture in your tendon?
So a great question, and I think very compelling question, because the fluoroquinolones have been, which is a family of drugs, including ciprofloxacin, have an antibiotic, as well as Levaquin, have been cited in a subset, fortunately small number of patients, as contributing to tendinopathy, which is breakdown in the tendon. Tendinitis, tendon fraying, and obviously going on to complete rupture. Fortunately, very rare. Dr. McGinn, would you comment on the mechanism in terms of tendinopathy? It's related to metabolism, but
I'll talk about it.
Dr.
Yeah, if you look at, if you actually take the cells that your tendons are composed of, called tenocytes, in tissue culture, and you add Cipro, one of these antibiotics, to it, to the tissue culture, the metabolism in the tenocytes slows down. So there's actually an effect on the cells in your tendons from these antibiotics. It happens in a small number of patients. Many patients, when they have this, get this tendon pain. They can also get swelling in a joint. You can also have swelling in a joint. We occasionally see knee synovitis from this family of drugs. Less common even than the tendon, but certainly it can happen. The good news is it's generally transient and resolves, and you do quite well. The incidence of rupture of the tendon is uncommon, but it happens. I think the question is, if you've had a reaction to a Levaquin or a Cipro like this, should you avoid those drugs? Well, I think the answer is to have a conversation with your physician, and if there's an alternative antibiotic that would cover whatever the problem is, you can make that choice.
And those are I would agree completely. That association, though, has been shown to be idiosyncratic. So there isn't a specific profile type patient that develops tendinopathy. I always say that's like having babies. You can have multiple babies, and every birth may be a little bit different. But intuitively, I like the concept of, can we try an alternative antibiotic, because I've had a problem in the past. So
I would not avoid the medications if you've not had a reaction, though.
Excuse me?
No, I'm saying if you had not had any negative experience with it, I don't think I would avoid. It is really relative. I mean, it's rare. And if there's any difficulty, you can stop the medication and you'll be fine. It is, as I'm sure our chair of urology would say, it's a very useful medication for many urinary tract infections and other things, and I'd hate to see people not take it because of this very rare event.
And realize, as an orthopedist, I see this with Lipitor as well. Patients have musculoskeletal complaints sometimes with Lipitor, but the vast majority of patients with musculoskeletal complaints are on Lipitor. So scientifically, it isn't that every patient who takes Lipitor or a ciprofloxacin or Levaquin is going to develop these problems, and sometimes coincidence occurs, and we have to be a little bit more thoughtful about that. Well, now we're up to the third part. So we've listened, we've obtained our history, we've examined the patient. Are there any tests that we're going to get? So let me ask Dr. Boal, do you, in John's case, where he can't walk and he has a pop, should you get an x-ray? Is it necessary?
I think it depends on the results of just as you said, listening and examining. And in most cases, we can make a diagnosis of a soft tissue injury and no fracture and move on and just go right into, the more conservative treatment. In many cases, that's as much as is needed. But if there is evidence or suspicion of a fracture or something that can be only picked up on an X-ray, then it would make sense.
So this is a normal x-ray of the tibia and the fibula of the leg. See a difference? So this actually shows fracture of both the tibia
Just
and the
point it
fibula.
out there, just in case.
Yep. Again, I apologize for those on this side. Look to your left. This is the tibia. You follow it down. You can see the fracture. And this is the fibula. This is what's called a comminuted, which means versus simple. Comminuted means multiple pieces. And this is also called a complete and displaced. It's out of position. Sometimes you can see a complete fracture line across the bone, but it's not out of position. This is a patient that would need surgery. Okay? And a compound is an open fracture. Compound fractures are very common in the tibia because if you touch your shin, the bone has very little soft tissue over it. There's no muscle in front. So many patients who sustain a tibia fracture, particularly high energy tibia fracture, motorcycle accident, motor vehicle, pedestrian type accidents, the tibia will come out through the skin, and that's a compound. Other tests. So that's a question for Dr. Hershman. Are there any other tests? We have examined the patient, maybe we've gotten the x-ray, the patient wants an MRI. The patient says, gee, should I get any other blood tests? I'm worried that I might be bleeding into my leg. What's the value of ultrasound? Are there any other tests you would get?
Sure. In thinking about the way the patient presented and how the physical exam looked, there's a sequence of things we can think about. First of all, the patient with the tibia fracture that we just saw in the x-ray, I can tell you that patient did not walk off the court, okay? And they called the pro, they called an ambulance. That's a different pop, okay? That's a major pop, okay? This person who went home, put ice on, elevated their leg, we have to think of a different set of diagnoses. Blood tests for this type of an acute injury usually are not helpful in the acute setting. Okay, so there's no blood test to help us diagnose an acute soft tissue injury. Maybe later on, if we see the patient's not improving, we may start to think about some other issues, underlying conditions, but initially, blood tests are not appropriate here. Let's talk about ultrasound for 1 second, because in the differential diagnosis, what we think about with calf injuries are blood clots, okay? And deep vein thrombosis can actually occur with these injuries. It's actually called effort-induced thrombosis. So if you go to see your primary care doctor or your orthopedist, one of the first tests they might obtain is a diagnostic ultrasound to rule out a deep vein thrombosis. Why? Because we always do the test that has the most dire consequences if it's positive first, okay? We're going to rule out what's going to be fatal, okay? After that, we can take our time. So we want to know if you have a blood clot, because that can be a pulmonary embolus.
But could you tell that on physical examination, Elliott? Could that be?
You cannot differentiate in this setting between an effort-induced thrombosis and a medial head of the gastroc strain. So that's what we're entertaining here, the calf strain, and we're ruling out a deep vein thrombosis. If the ultrasound is negative, okay, so we don't have a deep vein thrombosis, and we're not sure if we're dealing with an Achilles injury or a musculotendinous junction injury in that musculotendon unit, then an MRI is indicated. But many times, this diagnosis can be made just from a physical exam and listening to the patient.
So I think those are some very good points, and I would share with you that in treating these types of patients fairly commonly in my practice, I do not routinely get an MRI. I'd like to share with you, though, these MRI images. This is a transaxial cut, which means if you take the patient and cut them basically right across with a saw, you can get a cross-section of the bone, the muscle, and then the fat, which is white. So bone is white, muscle is gray, fat and skin are white. What you have here is an actual almost herniation of the muscle where the muscle is torn. And you can see that with the blue arrow. Here you can see the normal contours. This is now a cut that we call a coronal cut. These are the planes that you look at the body. So you can look at your body this way, you can look at your body this way, or you can look at your body transaxially. On this coronal cut, you can see this irregular contour where there is an injury to the muscle. So I don't routinely, I agree, to get an MRI in these patients. Sometimes patients come to me with an MRI, though. So I have a question for all of you, and the question is, now that we've gotten our history, we've been able to examine the patient, we have some tests, what do you think happened? Did John fracture his leg? Did John rupture his Achilles tendon? Did he develop a tendon injury? Does he have a muscle tear? Or, as Dr. Hershman pointed out, could this be a blood clot? Go to the music, please.
So use your clickers.
So 63% feel that John has a muscle injury, muscle strain, 27% possible tendon injury. Very rare. I agree that we do think that a red flag, not always, for a fracture is you cannot walk off the court. You wouldn't limp off the court, you wouldn't get up, in general. Achilles tendon ruptures, remember John's age, 63, are uncommon. Achilles tendon ruptures tend to occur in patients between the ages of 35 and 60. He could have it, but it's less common. So people actually don't always rupture, and it has to do with the position of the foot and the muscle mass required to pull the Achilles apart and cause a rupture. So it's your position of your foot in terms of how your foot is planted on the court, sudden acceleration, deceleration, and that's how you tear your Achilles. So it would be lower on our list. Blood clot, in my practice, I see every once in a while in association with the muscle injury. And that has to do with the fact that patient's limping, they have pooling of blood, they're not their normal it's like flying in a plane. They're not active after they develop a muscle injury, and they can develop a blood clot. In fact, all my patients that develop a muscle injury, I will put them, if they can tolerate, on some type of aspirin to reduce their platelets and reduce the risk of a deep vein thrombosis. Dr. Boal, any comments?
No, I actually agree. I think my guess is, Dr. Sgaglione, that this patient, if they presented to your office, you would limit imaging, and again, based on physical exam and the history, would pretty quickly get down to what you think it is, right?
Okay, so now we're coalescing our diagnosis. We're drilling down to make a diagnosis so we can make a decision regarding treatment. And again, we feel here that he does not have an Achilles tendon rupture. His pain on physical exam is mid-calf. His Achilles tendon Thompson squeeze test is negative, so it's a pertinent negative. His pop most likely was a muscle injury or a pull. We actually use the word tennis leg. So a gastrocnemius muscle injury has a mnemonic like tennis elbow, tennis leg. So what are we going to do? We talked about this on the initial treatment, but now you're at the specialist. We talked a little bit about ice. We talked a little bit about an ACE wrap. I like to tell patients, particularly if they come in and they're limping and they're wearing high heels, or they're wearing stylish shoes, or the men may be wearing a leather-soled shoe, or they're wearing topsiders, that shoes basically make a difference between you and the ground. And the most important thing about shoes when you're injured, whether you have knee pain, hip pain, or a gastroc muscle pull, is to make sure that your shoes are lace-ups. The reason being that the shoe conforms to the foot and transmits load from your body to the ground much more effectively if it's a lace-up. Topsiders don't have lace-ups. Sandals don't have lace-ups. Number two, when you buy a shoe or you want to be smart about the shoe, you need a firm hind cup. That means that the heel has to distribute load through to the sole using a firm hind cup. You want the back of the sides of your heels to have good side-to-side support. And the third thing is the sole, which is a rubberized type sole. What's the best example of that? The poster child for the right shoe to wear when you have a leg problem? A running shoe or a walker. And we think that is very important. Obviously, we want to modify activities. And part of that is the mnemonic of RICE. So we tell the patient, gee, maybe you need to take a day off from work or a week off from work. And you probably can't play tennis right away. And you want to be liberal with what we've discussed about icing. And we like the idea of a compression wrap. Anybody who watches the NBA these days sees that all the players have compression wrap sleeves on their arms. People wear compression wraps because they feel good. They also help distribute swelling better. And most importantly, I think what they do is they give you some sense of protection. And elevation, I think, is very important. So, other treatments. What about crutches? If a patient comes in and they're limping, they should be told and advised to use an ambulatory aid. So if you're limping, get on crutches. How do you decide crutches or a cane? It's the extent of limping, but more importantly is a lot of patients do not have the good upper body strength and balance to use crutches. So we will sometimes tell them that even a walker. So we get to the next step, which is now we have our diagnosis of a muscle pull. We have some treatments that we're going to recommend. What about physical therapy? I'd like to bring Ms. Nina DePaola up, who is our Vice President for Rehabilitation for the health system, who's going to make some comments about rehabilitation. You want to do it from there?
Thank you. Actually, I may ask Kevin to come up again. That would be great. Thank you.
While Kevin's coming up, a patient asked me here, we didn't talk about other vascular issues. If you have poor circulation, would that be something you picked up on the examination?
So the most important thing about poor circulation is beware of wearing wraps. I'll have patients come in with knee sleeves or wraps around their leg, and their circulatory status cannot support it, and then they'll develop swelling below the wrap. So I think we have to be cognizant of the full patient.
Okay, so what we typically do, just to give you some insight to the physical therapy piece of this, when the patient comes in with a clear diagnosis from the physician, so fractures have been ruled out, and we're dealing with this sort of muscular tenderness issue. We do look at the patient, but I think our job as a physical therapist is to make sure that we're going to create an individualized program for that person. So we understand what happened, but we want a little bit more insight as to how it happened, why it happened, and we can plan the program to make sure we can prevent anything from re-happening. So to give you some examples, as a therapist, what the therapist would do is they're going to look a little bit at the core stability, how strong is their trunk, do they get good power and stability from their core. If you've heard of core stability or core training, what that is, it's basically all the muscles that connect your shoulder blades, your spine, your pelvic girdle, and your ribs. And you're going to hear a lot today about the importance of balance with all of these issues. And it's so, so important as a priority to walk away today with a level of understanding that it's so important for us to strengthen our core, make sure it's stable, whether we're doing more aggressive type of activities with pulleys, or even just within your chair, just sitting and being able to engage your abdominals and doing pelvic tilts, little isometrics. So I just wanted you to walk away with that. But as therapists, again, with this particular patient, we're going to look at his core. We're also going to see maybe there was tightnesses and weaknesses in certain areas that may have predisposed this person to get a tear. So we'll look at his hip rotators, we'll look internal, external, we'll see how flexible his hamstring is, we'll come down in here, we'll evaluate the knee strength. But getting back down to this area, and again, as mentioned before, we first want to sense how uncomfortable are they today. So part of this evaluation is we do palpation. We'll feel where their pain is. Maybe it's a little warm, maybe it's swelling. We'll ask them, was this your dominant leg or not your dominant leg? We may take a tape measure and measure to see, was there maybe some chronic weakness that was causing a little bit of atrophy? The gentleman before mentioned back problems. Sometimes a chronic back problem can cause weakness in a leg, and then they go play tennis and they might be more likely to an injury. Moving down, we also look at the ankle and the foot. So I think what's really important, and Dr. Sgaglione mentioned shoe wear, but a really good part of a rehabilitation program would be an appreciation to what type of foot does this person have, what type of shoe wear are they using, were they using during the injury, and make sure we address that. So some people tend to have high arches, a very rigid foot, which can make them a bit more tight in that calf muscle. So we want to make sure that we pay extra attention to stretching. Other people may have a floppy foot, they call it a pronated foot, where they really don't have a lot of arch support. These are the folks that when they come into the clinic and they're wearing flip-flops, and you just kind of cringe, because you know they really need to be in a cradled environment with that heel nicely cradled. So part of the, again, the evaluation, we'll look at range of motion, we'll look at strength, we'll ask him to hold it right there, we'll feel the strength. We'll then get him to stand up, if you don't mind. Okay, and what we'll also start to look at with him, and I think there were slides, if someone wants to advance the slides, that's fine, or I could just keep talking. But part of the evaluation, if he can tolerate it, is we'll also start to, and during the treatment, look at balance. So we're going to have to assess his ability just to lean on that foot. Is it painful? Is it weak? Are his hip muscles kind of weak? How are we doing with that? Yeah. And then as part of his exercise program, we will be doing stretches. We will have an aerobic program, which I'll get into in a second. We will be doing specific strengthening exercises, the core conditioning I mentioned, and also the balance training. So we can move forward. For balance, we like to start off, and again, this is a common theme throughout a lot of our talks today, the appreciation of balance. We may start off the individual just standing on one leg, and we'll ask him to hold it maybe 3 to 5 seconds. We may ask him to close his eyes, just to have no compensation with his visual ability. That's a little more difficult. For safety at home, we usually have you hold something lightly with your fingertips first, but you should be able to stand on each of your leg, and we tend to have a bias to a particular leg. For at least 5 to 10 seconds, you should start to develop that balance at home. And then once that is easy for you, we'll tend to progress it. So we'll have the person maybe do a one-legged squat with the balance. We may have them do, he's having a hard time. And then we may have you also integrate this on a wobble board. There's all sorts of ways to do it. Doing certain functional activities or exercises while you're standing on one leg. We can be so creative, but the main thing is just to really address the deficits. Moving on from balance, aerobic exercise. So for this particular individual, we would tend to avoid anything that's going to stress the gastroc or the calf area too much so. And that means walking. We tend to avoid the treadmill, and especially an incline treadmill, until that person has no pain and is comfortable with their strength, and there's really no antalgia or weight bearing off of that particular foot. A great endurance exercise, aerobic activity that we could start almost from the beginning is just to put them on a bike. If they're concerned about their aerobic conditioning, go in a pool and start swimming. But a bike tends to be the preferred choice, or an elliptical.
Recumbent bike or standard stationary upright bike?
So I guess it depends on the patient. We have some patients who maybe if they have a back history, maybe they have a limitation in their balance or their core, if there's a level of obesity, they may be more comfortable cradled in a recumbent bike. And we can also move forward and back the seat. So if we want to bend the knee or straighten it a little bit more so, we can play with that. Are you all familiar with what a recumbent bike is? So it's kind of that seat, and you can bring it forward, back, up, and down. Gives you a little more play. Yes, sir?
Are you talking about the recumbent elliptical also?
Oh, that's interesting. Yeah.
Repeat the question.
The question, sorry.
I'm sorry, he's asking about the recumbent elliptical also. Yeah, there's different variations, and I think, again, the best thing is to have a physical therapist look at you with the piece of equipment, and they can recommend what might be best for you.
I have a question that is, how can you improve your flexibility?
Okay, so the next slide, beautiful.
I want to be able to do that.
Lovely. So, and again, a takeaway, and then, I just have a few more things to say, but I would say a huge priority in this sort of an injury and any sort of muscle tear is make sure you get the flexibility back. Stretching should always be pain-free. If anyone tells you to stretch to pain, you're going to cause more injury and more irritation and inflammation. So to give you a sample of a stretch, if you could grab the back of the chair. Or actually, Kevin, did you want to do it here, or what's easier? Okay. So we're going to show you. Dr. Sgaglione had talked about two muscles. One of them was the gastrocs, okay? And if you remember from your anatomy, the gastroc muscle crossed over both your knee and the ankle. So the gastroc muscle starts up in here, and it goes all the way down into the tendinous area to your actual heel bone. So in order to stretch it properly, he needs to straighten out that knee, and then lean forward with a nice posture, excellent, and keeping that heel on the ground, relaxing the shoulders, and a stretch you want to hold a stretch for 20 to 30 seconds for at least several times, and ideally you want to do this after a little warm-up, you want to do it before and after activity. But for therapy, I don't want him to stretch into pain, so he holds it and he comes back up. For the soleus, which is that little muscle, if you remember, underneath it, that only crosses the ankle, it doesn't go as high up, in order to rule out one versus the other, because your soleus might not be stretching so great with this if your gastroc is tear, I'm going to ask Kevin to bend his knee a little bit. That'll rule out the gastroc. And again, pitch forward with the hip. And I think when we did this before, you really felt the difference, correct? So again, gastroc and soleus. Next slide. Okay, and just to wrap up, therapy again encompasses, I don't want to gloss over it, but we do have modalities. We use ice, we use ultrasound a lot for these sort of gastroc issues. It's a deep heating modality, and the vibration of it can really help break up scar tissue and allow those fibers to heal in a nice parallel fashion. We may do massage, you could do self-massage, agility, getting back to tennis.
Should we go to the spa here? Is this an advertisement for the spa, the massage?
Yes, yes.
Does that help?
Spa service, yes. And then also general conditioning, like I said, head to toe, we want to get you back to your sport, back to your function. So you don't want to sell yourself short by just treating the calf. It's the whole body that needs reworking. Yeah? Yeah, so TENS, have any of you heard of TENS? Okay, there's different types of electrical stimulation. There's electrical stimulation that is helpful for muscle spasm and pumping out swelling. That's one type of electrical stimulation. Another type is TENS, T-E-N-S, it's transcutaneous electrical nerve stimulation. It's a different sort of thing. It actually stimulates your nerves, and it has been shown to help with pain, especially chronic pain. If you put it on a low pulse rate, you can have a release of endorphins, which is really, really helpful. We've used that for a lot of patients, more so with pain. It's not going to train your muscle or pump out swelling. Okay?
Okay, so great. Well, we're going to finish up with our patient because we've obviously, thank you. We've obviously treated the patient. So the questions the patient may ask us is, how long is this going to take to get better? So we have a gastrocnemius muscle strain, and the patient's still limping. And John wants to know, how long does that take? And it could be 6 to 8 weeks. Can I travel? Can I go on a plane? We'd like them not to go on a plane if they're limping. If they do, we are going to emphasize the potential for using aspirin or other anti-thrombotic agents. When can they start exercise? Immediately, particularly if they're going to supervised physical therapy. What about getting back to golf? Golf sometimes before tennis because there's less sudden deceleration and acceleration, and tennis later. And it can take a few months. And obviously that's dependent upon the functional recovery. And I think that's important to help define the patient. Many patients want to know how to plan. And so one of the things we do in sports medicine is projections. So we'll say, we think it may take a range of anywhere from 3 weeks to even 3 months, because there are subsets of patients that will take longer. What I'd like to do in terms of summarizing session 1, I think, is comment on exercise and conditioning as well as avoiding risk factors for injury. We really do, and I think, place most of our concern with injury prevention. And so the take-home message for injury prevention, if you're a tennis player or an athlete or you're exercising, particularly with sudden cutting and shifting and deceleration, acceleration, is the importance of proper stretching before you play and proper warming up before you play and then cooling down with stretching. So that probably is the most important thing to do. Second thing is common sense. That is not to get out there if you haven't been playing all winter or you've taken some time off and bring your A game and maybe overdo things. I like to tell people, try to play with better tennis players, people who hit back to you rather than spray the ball. What about...
Nick, at this point in time,
Pardon me?
I'm being the bad guy. You have one last question here
Sure.
for clarification, and then our time is up. The bell is ringing.
In relation to massage therapy and how it would apply as a modality in this case, could you please speak to maybe the different certifications in massage? We talked about spa massage and the different practitioners that might be at a spa versus other massage practitioners that might have a specialty certification in sports injuries or medical massage.
Ms. DePaola?
Sure. There's, am I on?
Yep, you're good.
Yeah. There's all sorts of types of manual therapy. By all means, a massage therapist, a licensed massage therapist, may be working in a spa, but a clinically based massage therapist may be working either in a chiropractor's office, may be available for you in this type of injury to do a really nice soft tissue massage work. Physical therapists are also trained in massage. Typically, you need a good 20 or so minutes of manual work, and sometimes during the therapy session, it might be a little, short in time. So if you needed supplemental manual work, by all means, a licensed massage therapist would be a great person. There are certified athletic trainers who also do a bit of manual work as well. Those are the three that I would tend to say would be helpful for this sort of condition.
So Dr. Smith, I think we need to get Dr. Gavuzzi a violin because it could be like the Academy Awards. They just start playing the music and we finish. Last point, exercise. So there's only one thing you want to do besides stretching. Get on a bicycle, stationary, spin for 20 minutes, no resistance. Start every day. After 2 weeks, add resistance and increase the time. That's your take-home message. Thank you very much.